Management of the pelvic organ prolapse. First is conservative, then surgery. Conservative. First one is lifestyle changes. Ask the patient to reduce weight and avoid heavy weightlifting, especially after the delivery. If the patient is suffering from some disease, then treat the cause. For example, in COPD, due to the chronic cough, intra-abdominal pressure will be high. That can lead to the prolapse. So treatment of this COPD can prevent the prolapse. In postmenopausal female, the most common cause of prolapse is estrogen that lead to the atrophy. So if you want to reverse that atrophy, just give her the estrogen. So estrogen replacement therapy can be done to reverse the atrophy. Number 4 is pelvic floor exercises. The patient should perform 8 contractions per day for at least 3 months. How can you recognize the pelvic floor muscle? During the urination, when you try to stop the urine in the middle, the muscles which are used for this purpose are actually the pelvic floor muscle. You have to perform that exercise, that also known as Kegel exercise, for at this frequency for 3 months. Also, the pelvic floor exercises first line management in stress incontinence. What is stress incontinence? Involuntary urination during due to the raised intra-abdominal pressure, that may be due to the cough or laughing. Also, in young girls, when they perform these exercises, their pelvic floor muscles will be strengthened, and they will be at lesser risk of developing the prolapse in the later age. In the male, these exercises also help to maintain the erection. Fifth, in the conservative management is pessary. If we have the vaginal canal, cervix and the uterus, that uterus can protrude downward. So we insert a sportive structure in the vaginal canal. That sportive structure is actually a pessary, which prevents the downward movement. It is available in multiple form. This is the ring form of the pessary. It is more acceptable because the ring pessary will preserve the intercourse. With other shapes, the intercourse is not possible or is painful. In the what are the indications for pessary? Since these are conservative, so not the ultimate or the definitive management, the indications are temporary use for the decubitus ulcer. In the decubitus ulcer, first we have to treat the ulcer, then we can go for surgery. So for treatment of the ulcer, we will reposition the prolapsed organ. For the repositioning, we will use pessaries. After that, packing of the ulcer will heal, and then we can go for the surgery. So this is number 1 indication. Second is pregnancy. In pregnancy, the pelvic surgeries are contraindicated. So in order to treat that prolapse, you will go for the pessaries. If patient is contraindicated, there is any contraindication medical to the surgery, then pessaries are the option. Or the patient refuse to go for surgery, then again you have to choose the pessary. The important care for the pessary is we should change the pessary or rewash it after every 3 to 6 months. And the long-term complications due to the placement in the vaginal canal is ulcer or fistula. After the conservative management, if the prolapse is very severe, we will not go for the conservative. If the conservative management is failure of the conservative management, then surgery will become the option as a management plan. Now, before going for the surgery, you have to differentiate between uterine prolapse and vaginal prolapse, because the management will be different depending upon the types. Diagnosis is mainly based on the history findings and the examination finding with speculum vaginal examination. Investigation, which are rarely required, but we do when there is a preoperative baseline is done. If there are urinary symptoms, you can do for the urine analysis and urodynamics. For the bowel obstruction, sigmoidoscopy and rectal manometry is an option. If you suspect mass or swelling, ultrasound of the pelvis abdomen can be done. For COPD, you can do X-ray chest, and hydronephrosis or ureter is suspected. You can do the X-ray kidney, ureter and bladder, or renal function test. Now, the patient who came to you with for a surgery with uterine prolapse, you have to go look into the age of the patient. If that patient is premenopausal and she is nulliparous, N stands for nulliparous. Nulliparous, the most important risk factor, if we revise for this prolapse, is gestation, multiple gestation. But she is a nulliparous. A nulliparous woman who present with the prolapse, that prolapse is actually a congenital uterine prolapse. So it is referred as a congenital prolapse. Now, obviously she is nulliparous. She don't want to remove her uterus, otherwise she will not have the child, and she want to have future pregnancy. A nulliparous women who want to have the pregnancy, you will not do the hysterectomy. Instead, the treatment is cervicopexy, cervix suspension. It is also known as sling surgery. SS stands for sling surgery. How you perform this surgery? This is the cross section of the pelvis. We have the uterus, rectus sheath. Anteriorly we have the pubic bone, posteriorly the sacrum. This is the promontory, sacral promontory at the right side and the left side. This bulge is due to the sigmoid colon which is passing through the left side. Now we just take the sling and attach one end of the sling to the uterus, and the other end of the sling can be attached anteriorly or posteriorly. If we attach it anteriorly to the anterior superior iliac spine, then this surgery is known as anterior sling surgery. And if we attach this sling posteriorly with the sacral promontory, then it is known as posterior sling surgery. It is just analogous to the uterosacral ligament, sacral promontory. Since sigmoid colon and genitofemoral nerve are passing through the left side, so the posterior sling should not be passed through the left side. It must pass and attach to the sacral promontory from the right side. And if for the severe prolapse, we can also use the combination of both, that is known as composite sling surgery. We can also use anterior as well as posterior sling surgery. Now, if the female who came to for the surgery is premenopausal and she is parous, she has the parity, she has children, she underwent the previous gestation, so she is not a congenital uterine prolapse, not suffering from the congenital uterine prolapse. She is suffering from the uterine prolapse, which is in the parous women. And that female, when you give her the options, she said, I don't want the hysterectomy, maybe in future I want to be pregnant. So so hysterectomy is again not an option for this lady. There is another conservative surgery which is known as Fothergill surgery, which you can do in this patient. This Fothergill surgery is done in 2 steps. Step 1 is cervical amputation. It is actually a partial amputation of the cervix. When a foreign material is placed in the cervix, it will lead to the reaction that causes the fibrosis and the adhesions. These fibrosis and adhesion will act as a supportive structure there to prevent the prolapse of the uterus. This is step 1. After step 1, you will go for the plication of the cardinal ligament. What is plication? Since cardinal ligament is supporting the uterus from laterally, we just reposition that cardinal ligament anteriorly and attach them anteriorly. It will provide support to the uterus and keep it in the anteverted and anti-flex position. So now the uterus will have 2 strong support. And on the back side it is uterosacral ligament, and on the front side it is cardinal ligament. This is known as plication. But there is a risk factor associated with this Fothergill surgery. This fibrosis and adhesions can ultimately lead to the stenosis of the cervix, and when that female become pregnant, there is a chance of second trimester abortion. So there is modification to this surgery, modified Fothergill surgery. In the modified form, we only do the plication of the ligament and we avoid the cervical amputation. So this is the treatment for the premenopausal women who came with the uterine prolapse. Now, if the female who came with the uterine prolapse is postmenopausal, so there is no chance that she can be pregnant in the future. So we just simply do the hysterectomy through the abdominal or pelvic or vaginal approach. Now, if the female came to you with prolapse, but it is not the uterine prolapse, sometimes there is a combination of all, so you can do all the surgeries at a time, but we will discuss separately. Surgery. Now she came for the surgery and she is suffering from the vaginal prolapse. In the vaginal prolapse, we have discussed previously, there could be the vaginal vault prolapse, or there is a cystocele or rectocele, depending upon the location. If there is a vaginal vault prolapse in the post hysterectomy lady, the vagina which is prolapse protruding downward, we will have to suspend it in the original position in order to preserve the sexual activity. Now we have 2 different approaches. We can use 2 different approach. We can take the sling or suspension sling and attach it one end to the vault, and the other end could be attached to the sacrum. And when we do attach it to the sacrum, we are actually approaching this through the abdomen. So it is also known as sacro, because we are attaching it to the sacrum. Colpo refers to the vagina. Pexy suspension. So this is one of the option. But if that female has underwent the abdominal surgery previously and there are some adhesions that are contraindicated to the abdominal approach, then we use the vaginal approach. In the vaginal approach, you will suspend that vault of the vagina with sacrospinous ligament. So sacrospinous ligament fixation can be done. These are the two options in the vaginal vault prolapse. What will you do for the cystocele or the urethrocoele? There is a defect in the anterior wall of the vagina. What we cannot just suspend it as we done previously. We have to repair actually. We will remove the defective part and apply the suture. Removal of the defective part and application of the suture. This method, since it is done anteriorly, so this surgical option is anterior. We are repairing the vagina. Vagina refers to colpo, and we are actually repairing, not suspending. There will be no pexy. It is raphe, repairing. Anterior colporaphy. Similarly, for the posterior prolapse, which is seen in rectocele or enterocele, the defect or the bulge is present in the posterior wall. We have to remove that part and apply the suture and approximate. This method will be known as posterior colpovaginal raphe repair. So these are the various options which are available for the management of the prolapse.